we've restructured it a little bit, and we've reviewed most of our SG sessions to include new cases so that you don't have the answers from the last iteration, but that also it is more challenging to you when you do it this year. I think one of the other things that we've worked really hard on is to provide more feedback to students. One of the comments that we got from the last iteration of the course was that there was a lot of content in this course, especially lots of science content, and students felt that they didn't have enough opportunity for feedback to know how they were going. So this year we've included lots of opportunities where you will get feedback. You will get feedback in SGS 4 and 8 from your facilitators, but we've also included quizzes in almost every SG session, so you can use that to gauge how you're going. And besides that, for most of the science elements in the course, and especially for anatomy, we've developed a whole lot of adaptive online tutorials that you will have access to, and that will give you feedback on how you're going. We would also appreciate your feedback on how these tutorials are. So in a number of occasions, we'll actually ask you, maybe formally and maybe informally, so we'd really like to hear from you whether these resources are helpful to you. The other thing that we have included in this course is we've included Blackboard discussion boards. As in the last time, there is discussion boards on all of the different science elements. There's also discussion boards on the 3 scenarios that are in this course. So when you have questions, when you have things that are not clear, please post onto that discussion board and don't feel shy to use it. We are aware that you have a whole lot of discussion that goes on Facebook, but we do encourage you to use this discussion board to get the expert answer from the discipline and to be absolutely sure that the answer that you're getting is correct. So you're quite welcome to have your other discussion, but if you need to verify things or just double check things, post it up on these discussion boards. You'll actually be surprised at how disappointed the discipline experts are when they don't get any questions in their subjects. So please post questions so that they're actually also encouraged by your learning. There's also discussion boards on projects and assignments, and we'll talk about that just now. So, this course, Aging and Endings, runs in 2 cycles. It is an A cycle and a B cycle. There are 4 themes that we cover in this course that are listed up on the projector there. And in Aging and Endings A, which is what we're doing now, we will actually be focusing on those 3 that are highlighted in red. So we will talk about the aging process. Really, a lot of the aging process was related to the musculoskeletal system, and then a little bit of aging related to cancer. We will talk about degenerative disease in terms of arthritis and also in terms of pain and palliative care. In this course, students actually do find some scenario group sessions confronting because we do deal with concepts around death and ethics around death, dying, and palliative care. And we have taken every caution to make sure that these are as nicely presented as possible. Okay. I won't do that. Okay. From the last iteration of the course as well, the students said back to us that they were concerned about the volume of homework that is in this course. We ourselves are very concerned about homework because we do realize that this is the last course in this year, and it is also the last course in this phase before all of the cycle of exams that come. We have tried to minimize the homework, and so we've given you homework in only 7 of the 13 SGS sessions that you will be having. That is half the SGS sessions. But the form of homework that we have is mostly in the form where you would do presentations, and our rationale for that is that when you prepare presentations to teach the rest of your group, you're also learning the information. So take that as a twofold thing. One, that there is homework, but it's also done in a way that you would be constantly learning. There are 3 scenarios in this course, and the 3 scenarios we will take you through in the next 7 weeks. The first one, which you start this morning, is on osteoporosis, and you meet a lovely old lady called Alma Jones, and we'll do that in a few minutes and talk about that. But in about a week and a half, you also start the next scenario, which is on arthritis. And for that scenario, we are really lucky in that we have some really good discipline experts in the field to actually come and talk to you, and also to provide you with examples of real-life patients that are living with arthritis. The last scenario is on bowel cancer, and we'll talk about that more later. In this particular scenario that we have starting this morning, we meet Alma Jones and we talk about aging, we talk about joints, and we talk about bones a lot. We talk lots about falls and the consequences of falls. So besides all of the information that will be a broad suite that you get in the next 10 minutes from an expert in osteoporosis, you will also deal with other social issues in terms of aging and how that may impact people suffering with osteoporosis.
Okay, so there are 6 assignments and 6 projects in this particular course, so please take note of the various deadlines. So we have quite a few projects. Maybe we'll go forward. Yeah. So we've got several assignments, several projects with quotas. There is an exempt assignment for this course, but being granted an exempt assignment is based on your academic record and, of course, having achieved all the graduate attributes that are expected for Phase 1.
And for second years only.
And for second years only, of course. So that will be decided after the first week, when everyone's had time to actually lodge their application for that. So you can probably have a look through these in your own time. Yes, let's go to the projects. So Project 1 and Project 2 are a type of project that we have run every time we do this particular course, and it's very popular. And there is a quota of only 10 groups for each of those. So I appreciate that some people may have SG sessions that are Tuesday and Thursday. So after you can put your application in for those particular projects, and we won't make the decision until very early in the second week, so next Monday, in other words. I think that's pretty much all that we need to say about those. Yeah.
Okay, so now to start the plenary, we're actually going to play you a video in which you will meet Alma Jones, and afterwards we have Dr. Salecki, who is going to give you a plenary on osteoporosis. She is actually one of the experts on osteoporosis, does research in this area, and so her information will be really, really valuable, and any questions you have for her would also be very good if you have time to do that. Okay. Yes, but where's the sound? No. I think. But the sound from the video? There we go.
Mrs. Jones, come in. Oh dear. Just come have a seat on the bed here for me. You would. So how are you today, Mrs. Jones? Not bad. Not bad. See, you've done something to your arm?
Yes.
So what happened?
Well, I was going out the back door, down the back steps, and it's been raining, so I slipped down the bottom 2 steps. And I put my right arm out to save myself, and then I heard a crack. Oh dear. And very painful in my right arm. And then
did you call out? Or?
I did. It started to look funny.
Oh,
it was looking funny, and so I called out, and a neighbour heard me, and she came around, and as soon as she saw it, she called an ambulance.
Fair enough. So you went to the emergency department straight away?
Yes, emergency department. By the time I got there, I couldn't move my wrist.
Oh dear.
And my hand and my fingers were swelling up, and my arm. And so they sent me straight for an X-ray. And after that, they told me that, yes, it was broken.
I'm sure you weren't surprised by that.
No, I wasn't. I knew there was something. It was something really looking strange.
Yeah.
So then they injected an anaesthetic.
Yep.
Then they moved the bones back into place.
Yep.
And then they put a plaster.
Okay, that plaster there. How's it feeling?
Well, it was okay at first. My fingers and my hands swell up at night.
At night time,
Yes, it'll wake me up actually.
But not during the day so much?
Not so much, no.
Okay, yeah.
Yeah.
And is it very painful in the hands, or do you feel anything else in the hands?
Well, I feel pins and needles mainly.
All right, whereabouts in the
Well,
hands?
the thumb
Yeah.
and first two fingers.
Okay,
Yes,
all
pins and
right.
needles.
Okay, so the last two fingers are fine?
Yeah,
No pins and needles
okay,
there?
no. Okay, absolutely fine.
Okay, that's a bit unusual, isn't it? When you sort of,
Well,
for you must think it's a little bit weird. It's not, just so
Oh,
you know.
really?
Okay, I'll explain it to you in a second. So other than that, other than the pins and needles and the swelling, you're sort of feeling okay?
Yes.
Yeah, and how are you functioning at home?
Well, my husband has to do most of the cooking.
Oh dear, how is he? Is he a good cook?
It's pretty ordinary.
That's all right, stay for a little while.
It's a learning thing, you know, like I just didn't realise how much I did with my right hand until this happened. I can't write. I can't write at all, so...
Do you mind if I have a look at your x-ray?
No, thank you.
Okay. I mean, really, I'll just explain to you what's causing these symptoms, okay, just so you understand. There are two things that could be happening here. The first one is it could be related to the plaster. When you have this sort of injury, you get a lot of swelling, okay, inside the arm, around the wrist. So all the fluid from the body tends to go into that area to try to clean out what's going on in there and sort of get rid of it. And when that happens, you get a lot of fluid which sort of collects. And unfortunately, that means that you get swelling, okay, in the hand and in the arm. Okay. Now, as far as the pins and needles go, there's actually a nerve that goes from your elbow all the way down your arm, goes through your carpal tunnel, okay, and then comes out and basically supplies this half of the hand. And the edge of this one too. So you may not have noticed that symptom. Okay, and that's why you've only got symptoms on this side, and that's called the median nerve. Okay. And so when it all swells up in here, that can compress on the nerve, all right, and that can cause these symptoms, and that's why it comes and goes. Do you get the symptoms all the time, or mostly at night?
Mostly at night.
Okay, that's a good sign. That means it's probably related to the swelling. I must warn you though, there is a small risk that with all the injury that's happened in the wrist and with all the swelling that's gone on, we may have damaged that nerve, okay? Alright, if it is damaged, it will heal, but nerves actually take a lot longer to heal than any other part of the body. So we're talking sort of 3 to 6 months, maybe up to a year sometimes. Okay, well let's have a look at the hand now, shall we? Okay. Good. Alright, it is a little bit swollen, but it's not too bad. Are you still feeling the pins and needles at the moment?
It's a little bit.
A little bit? Okay, alright. I'm just going to start by touching your fingers. Just tell me if you can feel me touching. Can you feel that?
Yep.
Here?
Yes.
Okay.
Yep.
And that side?
Yeah.
And that one? Good. Do they all feel the same?
No, the little finger and this finger feel different.
Okay. Well, if I rub on both sides of the finger, do they both feel the same?
No.
No. Okay, this side feels more normal, doesn't
Yes.
it? And that's a bit numb.
Yes.
That's normal, okay?
Okay.
What happens is that median nerve I was talking about actually supplies this part of the finger, but not that part.
Oh, okay.
Alright, so it's a bit unusual, but that's completely normal to have happen. Okay, good. Now I'm just going to do a couple of exercises, alright? I want you first of all to take this thumb and just put it up as high as you can like that. Good. And keep it up there. Don't let me push it down. Excellent. Now I want you to try to bend and flex it. Good. And just as much as you can, can you put your thumb across to the base of that finger there?
That's as far as I can.
Yeah, no, that's fine. Okay, that's good. Excellent. So what that tests is to make sure that the median nerve is still working in terms of its function. And that's all working fine. So that's a really good sign. Okay, so even if there is a bit of nerve damage, it's only the sensory stuff, and your thumb's working really well, and as you can imagine, your thumb's a pretty important part of your hand. That's why we're human, opposable thumbs. And so therefore, we're not too worried now. Even if there is a bit of nerve damage, we're going to be okay. Alright, good. Now I just want you to curl your hand up for me. Good. Is that cutting in at all, the calf, into your hand?
Not really.
No, you
Can
can
feel it there. But
Okay, and straight back out again. Good. So that's all moving really well. You've got good vascular return. Not too tight. Excellent. Good. These things are going well.
good. One thing I didn't understand, when they put the anaesthetic in and then they pushed the bones back into place, if it was a broken wrist, what were they doing then? So that
Okay, alright. What I'll do is I'll show you the x-rays and then explain to you exactly what it looks like and why they were moving things around. I'll get you to come up here and have a look for me. Okay, so this is your x-ray here, okay? And this is your hand, and that's the fracture just along there, alright? Now, I'm just going to show you on this, it's probably a little easier for you to understand on this map. Basically, when you had the fall, you said that you sort of fell, how did you do it, with your hand out?
put out my hand.
Like that, yeah. So when you fell, your hand hit the floor here. Yep. You can imagine the floor's pushed through, okay? And what it does is it basically, your bone breaks here and goes on a tilt, up and back into the bone. And you end up with what we call a dinner fork deformity. So it looks kind of like a dinner fork, if you can imagine what that sort of is like. So that's what you would have had, and what they would have had to do is to pull it out to reset it, which is what you would have had to experience in the emergency department. Now, unfortunately, what that means is that in that the nerve kind of gets sort of all, tangled up in the mess of what is the actual injury, and that's what causes the injury and causes this tingling and problems. So you can see on here, okay, so this is your radius here, and that's the one that broke. It probably broke around about here. Alright, this is your hand like this. Yeah. Okay, so that's the bone that broke. And in this one here, you can see that this yellow thing is the median nerve. And the median nerve comes up right near where the radius would be, and goes under the carpal tunnel into your hand and comes out and supplies all of these things up here. And that's where your symptoms are coming from. Okay, so the pain you're getting is coming not just from the broken bone, but also from the soft tissue inflammation, and also from the effect on the nerve. Yeah, so there's a lot of things
that
going on.
feels, when I touch that, and when I touch that, they feel different.
Yeah, doesn't it? It's a bit unusual. So that's what's actually going on. Okay, let's go have a seat again and see our conversation. Alright, so now you understand what's going on in here. It's a little bit yucky, isn't it? So basically the plan is we'll keep you in the cast for 6 weeks. Okay? And you've got an appointment with the fracture clinic in 2 weeks' time.
That's right, yes.
Okay,
Giving me the appointment.
good. And they'll re-x-ray that and make sure that's all healing up well. And you've got the card for that, and you've already got the appointment.
Told me that, yes.
Okay. And after that, when they take the plaster off, then you might need some physio, okay? Because being in plaster for 6 weeks, you get quite sort of weak muscles. And so sometimes we have to give you some physio, but we'll wait till the 6 weeks is up and see how we go with that.
All right.
Okay? We've got something a bit more important to talk about today, related to the arm, and that's osteoporosis. Now, you've heard of osteoporosis. Yeah, that's right. And basically, it's, when the bones become weak and fragile, because there isn't enough bone inside them, basically, and they're sort of a little bit weaker than normal. Now, in this case, we started you on the HRT, as you remember, and that was meant to...
Yeah, it was.
Unfortunately, it looks like it's not working as well as we'd like. So we're going to try to start you on a new medication, if that's okay with you. It's called Fosamax. Okay? It's a bisphosphonate. You just don't need to remember that.
I'd just like you to write it down for me.
Yeah, no, that's fine, I'll do that. And what it does is it actually stops the bone from being reabsorbed by the body. Okay, so it stops us from breaking down the bone in the body. So whatever is there will hang around for longer and therefore make your bone stronger. Alright? It's a great tablet to take because you only take it once a week. And you can pick the day you like. The only thing, it does have some side effects in the tummy. Now, I know you don't have any ulcers in your tummy, you never had trouble with reflux, so hopefully there'll be no problems. But if you do notice any tummy upset, vomiting, nausea, pain in the stomach, let us know and we'll review that and see whether it's related to the medication. We might need to stop it. Okay? Now, there's 2 other medications I'd like you to take. One's a calcium supplement and one's a vitamin D supplement. It's also called Osthon. Okay? Now, these are good because they actually help to build up bone. So we're trying to stop you from breaking down bone and also build up bone that isn't there yet. And hopefully that means your bones will be stronger. And you take both of those, one tablet once a day. Okay. And the only other thing I need you to do, obviously, is exercise.
Well, I do walk.
You do walk?
Yes.
How much would you say you walked?
About 40 minutes a day.
40 minutes a day? Or you're exceeding my expectations. We usually recommend at least 30 minutes of low impact exercise a day. So that's perfect. Okay, good. So the plan is cast on for 6 weeks, review with Fracture Clinic in 2 with an x-ray. You'll come and see me as well in between, okay? And we'll start you on the Fosamax, the Oscillin and the Caltrate.
All right.
Yeah.
And that goes on all right with my other medication.
That should. Do you have your medication with
Well,
you?
I
I'll
do.
just have a look. Great. Excellent. Thank you.
And also they put me on Panadine Forte.
Panadine Forte, yeah, for the pain.
Yeah.
And is that working well?
Oh, yes. Very good.
Okay. Just remember, Panadine Forte can make you a bit constipated. Okay. So if that's the case, then you should sort of increase your Metamucil if you're taking that. Or there's also a tablet called Coloxil with Senna. You can buy it from the supermarket. 2 little tablets, really good for keeping the bowels working when you're taking things like Panadine Forte. Don't let it sort of build up.
No.
All right.
Okay.
No, that shouldn't be any problem, any of those medications. What you've got here is fine. So I'll just add them to your list. Okay. And that shouldn't be a problem. Do you have any other questions at all? Anything I haven't explained well enough today?
Well, did I ask you how long I was going to be, unable to perform with this arm?
Right. Probably the 6 weeks.
Yeah.
With the physio afterwards, maybe a couple
Should
more
be
weeks
right.
after that.
Yeah.
But at least 6 weeks. In a younger person, maybe 4. But in a slightly older woman such as yourself, we'll go with 6 weeks.
Okay. That's fine.
What our plan is, I'll probably see you in, say, a couple of weeks, assuming everything's going well.
Yeah.
Actually, no, we'll make it, probably make it 3 weeks, so you'll see the Fracture Clinic in 2.
Yes.
Okay, so I'll give you that back. You keep your x-ray. And if you have any trouble in between, let me know.
I will. Thanks,
All right.
Doctor.
Thank you, Jones. You have a nice day.
Yes?
Can I ask you to use
Yes,
the
sure.
recording?
All right. What's the best? There we go? Okay. Good morning. Good morning, everybody. Hope the microphone's working. I'm Dr. Yvonne Selecki. I'm really happy to be here to talk to you about osteoporosis. I have a medical degree from this university and a Master of Public Health, and I work at the Garvan Institute on clinical trials, trying new drugs for osteoporosis, as well as what we call translational research, translating research into daily practice, and specifically for me, doing computer software clinical decision support for GPs. So what I'm going to try and get through today is talk about osteoporosis and fracture, the impact of fractures in the elderly, its relationship to ageing, bone biology, just an overview on how it relates to the clinical picture, the importance of calcium and vitamin D and prevention, and also do a bit of a critique of the last video. So osteoporosis is very self-explanatory. Osteo means bone and porosis means porous from the Greek. And so the structure of bone that, is porous becomes more porous. So it is more easily breakable. And here's a microscopic view of trabecular in bone, where the pores become larger and larger and break. And osteoporosis is largely, except for some rare forms, symptomless. Its relationship to fracture is what is its main importance. And it gives us the concept of what we call a minimal trauma fracture, With osteoporosis, bones can break with minimal trauma, and in America they call it fragility fractures. But what we define that as, the fracture is due a fall from a standing height or less. And as you can imagine, it's a bit hard to tell what the force is from a fall, but for prescribing purposes and research, that's how we define a minimal or fragility fracture. So sometimes from a standing height, if you're on ice or something, you might fall with such force that anyone's bone would break, even if it's not osteoporotic, but that's how we define it. But in really severe cases, people can sneeze and break a bone. Or roll over in bed, so slightest trauma can cause a fracture. But the fractures that are mostly related to osteoporosis in the elderly are in the spine and the hip and the wrist, which are different sort of fractures that might happen in younger people, which tend to be more due to sporting injuries or other types of falls. And so you might be sitting there and thinking, why a fracture is so important? You know, they might, be inconvenient, but why are they such an issue in the elderly? Because they can cause significant impairments in daily living, which is much more of a concern as people get older. And the independence and being able to look after themselves is a larger issue for older people. Hip fractures, which also occur much more commonly in older people and with osteoporosis, are serious and are highly associated with the need for nursing home care after the hip is pinned and surgery. And there is also a remarkably high association with death, especially after hip fracture. And the other reason osteoporosis is important is that it's incredibly common and it costs a lot. So 1 in 2 women will experience an osteoporotic fracture in their lifetime. And that has increased a lot because people are living a lot longer, and osteoporosis for most people is a disease of the aging, but I will talk about other causes. And it costs a lot of money, not just for hospital care, but all the kind of care that needs to assist people who have impairments in daily living due to fractures. And the other reason it's important is it's not just a research field. We have really good treatments that significantly reduce fractures, osteoporotic fractures. They're straightforward with minimal side effects and minimal drug interactions. No drugs are entirely free of side effects and interactions, but the osteoporotic ones, compared to other drugs for other conditions, do have less. And astoundingly, more than 75% of those affected with osteoporosis don't get treatment. So I wanted you to kind of guess what you think the mortality for hip fracture is after 60. And I'm talking about a year after the fracture, because most people don't die at surgery or DVTs or the kind of things that happen just post-operatively. They die in the year after the fracture. And it's actually as high as 25%. And that's for people over 60, which isn't even, considered terribly old. And 25% of those over 60 will need nursing home care after the hip fracture. And it's actually the most common reason for needing nursing home care. So you can see the huge morbidity fractures cause in the elderly. And all osteoporotic fractures, not just hip fractures, have a 2-fold increase in mortality in women and 3-fold increase in men. And this is from research done from the Garvan, a large epidemiology study in Dubbo that's been following people with fractures since 1987. And so some of the other fractures that occur with osteoporosis that aren't so common in young people are vertebral fractures. And the problem with vertebral fractures is they don't heal to their pre-fracture shape like other fractures do. The deformity remains and causes dysfunction. And the other problem is they're often we call it silent, but that means undiagnosed. So a lot of women will experience back pain or other kind of symptoms, but vertebral fractures aren't picked up. And so clinically, older people, if you ask them, have they lost more than 3 centimetres of height, it's an indication to do an X-ray to check for a spinal fracture, because they may not have specific symptoms that they complain of. And as with Alma in the video, there's a decline in independence and a decreased quality of life. Here's a picture of a vertebral fracture, and there's an arrow pointing at it, but as you see, there's not a clear line of a fracture that you'll see in other bones. Vertebral fractures are defined as loss of height, so more than 20% loss of height is called a fracture. So you can see they're a bit different. And this is what used to be called the Dowager's hump, but I don't think that's politically correct at the moment, but that's what happens with repeated vertebral fractures. There's a deformity of the spine, and it can, depending how bad it gets, it can cause a whole lot of other problems because of compression and things like that. There's also what we call a cascade effect. So once someone has a fracture, an osteoporotic fracture from minimal trauma, their likelihood of having another fracture is 4 times in the next year. So it's just another reason why we like to diagnose and treat people early, rather than a long time after that initial fracture. And that's also a good reason why Alma was treated for osteoporosis from the time of fracture. Otherwise, that kind of follow-up can get lost. And here's a hip fracture due to osteoporosis. Again, it's more common in elderly people, because you find with younger people, if you tripped and fell, your reflexes would be very quick and your hand would protect your hip. You'd also have more muscle that would act as a kind of give you some spring to protect your bones more than elderly people do. So they tend to be fractures, osteoporotic. Also, we can't get away from falls and osteoporosis, because that's one of the main causes of the fractures, that's the main thing that we want to prevent. And with ageing, there's a whole lot of factors that are going to make it more likely that people fall. So things like proprioception, balance deteriorates as people get older, eyesight problems, frailty, slower reflexes, as I mentioned, people will fall on the hip rather than being able to protect themselves, a decreasing muscle strength, which can't be totally alleviated with exercise. Then there's all the problems with medications that can make people unsteady, or they need to get up at night to urinate and they're sleepy, and that's one of the biggest time where people fall, because they're not totally awake and they're sedated. Behavioural and psychological changes, people don't get out and exercise as much and are more confined. And unfortunately, there haven't been many things that we found that have prevented falls. And the really big things that have made a difference are cataract surgery for obvious reasons, people's sight improves, and looking at their medication and refining medication so possibly people aren't sedated or doesn't contribute to their loss of balance. So coming back to Alma and the video, I mean, if you remember my definition, fall from a standing height or less, Alma did not have a low trauma fracture. She fell down the stairs. And I'm not sure if you're aware, but the doctors are only allowed to prescribe medications for very strict criteria, and you're not really supposed to prescribe Fosamax unless someone's had a minimal trauma fracture. You're not supposed to get a rebate. The patient should pay privately if you want to do that. So it wasn't really a good example of osteoporosis, because you want to make sure that someone hasn't had a fall or some type of force that would have broken anybody's bone, and it's not necessarily osteoporosis. The other problem is she only had an X-ray, which is not diagnostic for osteoporosis. Sometimes in very severe cases you can see it, but it's not what's used as a diagnostic tool for osteoporosis. So what should she have had to see whether she had osteoporosis? If you're going to pursue a fracture that wasn't minimal trauma, is a bone mineral density test. And it's a good predictor of risk of fracture, and it can guide whether the Fosamax or any sort of treatments you've given have worked, and it aids to the doctor to explain to the patient why their bones are breaking more easily. So, and some other issues with Alma, the big thing that caught my eye was at the end of the consultation when she takes out a piece of paper and she's on 15 medications. And this is an issue for any illness in aging patients, is that they have a lot of other illnesses and a lot of other comorbidities, and you'll have to think about how this interacts with other people, with the other conditions they have, and really how realistic it is for someone to be taking something like 14 medications. And also Fosamax has to be taken without anything else, standing up with a glass of water and no food for half an hour. And how does that work with the other 13 medications? There's also compliance problems like you can find with any illness where there are no symptoms. That's why it was good it was done with this fracture, but osteoporosis, again, is like cholesterol or high blood pressure. They don't have symptoms. You're trying to prevent something. And if you just think of yourselves, how many of you have actually finished a course of antibiotics when you were told to finish it, but your symptoms went? And then you're asking people to take drugs daily for long periods of time. So compliance for osteoporotic drugs, as well as other ones, are very, very low, and it takes a lot of time from the doctor to explain why and to deal with what problems the patient may have with that. And then also it would have been reasonable for the doctor to have a look at the other medications she was on and whether they contributed to a risk of falls, or even if Alma was falling a lot apart from that trip down the stairs. So just to give you a quick look at bone mineral density tests, they're very low radiation, they're painless. They have a look at the hip and the spine largely. This is a sort of picture you get of the hip, and they measure total hip and specific areas of the neck, and a spinal bone mineral density test. This is the kind of picture you get at the end of it. But basically, osteoporosis clinically, and this is the only clinical test we have at bone mineral density, is defined as less than 2.5 standard deviations from the norm. And it sounds quite complicated, but that's how bone mineral density is calculated, at standard deviations from the norm from a healthy 35-year-old. I'll explain the reason to that a little bit later. But the bone mineral density test is like the cholesterol and blood pressure test. It tells us what the risk of fracture is more than any other indicator, even the number of falls. And so if you're osteoporotic, you have 5 times the normal risk of fracture, which is quite high. And it is a good predictor, as I mentioned. Age and history of falls also go into the predictor test. And there is a fracture prediction tool at the Garvan website. If anyone wanted to have a look at that, you can just enter in details and get results. And when we're looking at bone density rather than fractures, genetic factors, and this is also one of the studies we've done at the Garvan, accounts for 80% of it, so there's only 20% that can be done with environmental factors. Again, age is an overwhelmingly important risk factor, and the worse your bone density gets, exponentially your fracture risk increases. So at this point I wanted to talk a little bit about bone biology and bone formation, just briefly, to kind of look at how it connects with the clinical picture of osteoporosis. So bone is very dynamic. It is constantly being remodeled. Bits are eaten away and absorbed, and you replace your skeleton about every 7 years. Osteoclast, break down bone and release calcium, and osteoblast, a good way of remembering it is B is build up. Then go to the area broken down, secrete collagen, deposit calcium and phosphate onto the collagen to make new bone. And this is a kind of picture of what the process is. So, in a sense, the osteoclasts make continual pits in the trabecular bone, and these pits attract the osteoblast to build them up, and that's how you get new bone. This is a more detailed picture of this, and why I'm talking about this as well is that the treatments for osteoporosis have clear mechanisms. A lot of treatments and pharmacological drugs, we don't know all of its actions, but with the ones for osteoporosis, if you have an understanding of the bone biology, you can understand the mechanisms of action. And so, coming back to age, it's the major risk factor for low bone mineral density for a number of reasons. Throughout your life, there is that resorption, bone is breaking down and then building up. And as you get older, the breaking down accelerates and the remodelling decreases. So that balance is making good, strong new bone deteriorates with age. Also, you need vitamin D for this process, and especially if you think of elderly people that are institutionalised, they have very limited exposure to vitamin D, and that's another factor. Together with less physical exercise, which stimulates bone to resorb, and less estrogen and testosterone make age a bigger risk. And I'll talk a little bit more about that in a moment. So the really main biological important factors in bone is vitamin D and calcium. And vitamin D we largely get from exposure to the sun. And it works together with calcium. It increases intestinal absorption of calcium and phosphate, increases bone mineralisation, and it leads to bone resorption to maintain serum calcium. So they work together, vitamin D and calcium. But the problem is that the sunblocks and things like that don't allow vitamin D, and there's quite a large spread deficiency of vitamin D even in the Australian population. Then we have calcium, which is important for a lot of things, and I don't want to go into it too much because you have a whole lecture on that. But because calcium is so important for nerve potentials and a few other bodily functions as well, the body keeps calcium at a steady level. And what this means in practice is that we can't do a blood test to determine what someone's dietary intake of calcium is. Because if someone hasn't got enough dietary calcium, the bone will leach calcium to keep blood levels normal. So coming back to Alma, it would have been reasonable to ask what her dietary intake of calcium was before she put her on calcium and added like the 13th drug, and there is no test that we have for that. As I mentioned, bone keeps 99% of the body's calcium, and it's a reservoir. If calcium goes down, it will be leaked from the bone, even if it causes severe osteoporosis. You need vitamin D to absorb calcium in the small intestine, and unfortunately this process you absorb less as you get older. And parathyroid hormones are central to calcium and vitamin D regulation, so that's why hyperparathyroidism can lead to osteoporosis. I think I've mentioned that the main problem is that we can't measure people's dietary intake of calcium or whether they're getting enough by blood tests, but we can do blood tests for vitamin D. So coming back to Alma, it would have been reasonable to do a blood test to see whether she had enough vitamin D before prescribing her the 14th medication. But it is very difficult to explain how much sunlight to people, because there's been a big public health message about staying out of the sun due to sun cancer, and they have different amounts of exposure for different states. But in New South Wales, they recommend that you get sunlight for 10 minutes at least, twice a day outside those hours where you can get badly sunburnt between 11 and 2. So you can see how this might be complicated. The other problem is that really dairy products are our main source of calcium. I mean, you have to eat a kilogram of broccoli for, one small serve of calcium. So when we try and see whether someone is getting enough calcium, we ask what their dairy intake is and what is considered an ideal dairy intake is 3 serves a day. So that would be 1 cafe latte or cappuccino with milk and yogurt and cheese. So you can see how a lot of people who don't take dairy for a whole lot of reasons would be getting low levels of calcium. But the only few things that do have high levels are sardines and white bait and fish when you eat the bones with them. So some of the other risk factors that, for osteoporosis are age, being female, and that's largely due to menopause, because after the menopause, estrogen drops so precipitously, and estrogen is one of the receptors on osteoclasts. That's the main time where osteoporosis starts. Also, a long-term low intake of calcium, which is hard to measure because we only can go on people's reported diets. Estrogen deficiency, so if people who have low weight, anorexia, miss their periods, they have a high risk for estrogen deficiency. Low vitamin D, smoking, heavy alcohol intake, and being thin or having a small frame. And I think osteoporosis is probably the only disease where being overweight is actually protective. So, but I don't think it's widely publicised. But even at the Garvan, they've done a big study where abdominal fat is actually very protective for osteoporosis. There's lots of reasons, and partly fat stores estrogen. So if you go back to the biology, you can work out these things. I've put up this picture of Gwyneth Paltrow just to do a kind of case history, just for illustration purposes, but she widely reported that she had a minimal trauma fracture at the age of 37, and she was tested and she had osteopenia, which is just minus 2 deviations from the norm on a bone mineral density test, and incredibly unusual for a 37-year-old. And then she reported that she hadn't had a dairy product for 20 years to keep slim, plus she never went outside. She protected her skin from wrinkles and had no real sun exposure. And despite the fact of having vegetables and all sorts of, chefs, and she's also probably underweight as well. So it's not just a disease of ageing, but if you think of those general principles, that's when you'll find osteoporosis outside of the ageing population. So there are other causes of osteoporosis, and I haven't listed them all. The main ones, and that's glucocorticoids, which prednisone is what it's called, and it's used for so many illnesses, rheumatoid arthritis or autoimmune diseases. So a lot of people, and younger people, may be on prednisone, and if you're on more than 7.5 milligrams for 3 months, we usually treat people to prevent osteoporosis because it has such a strong effect, bone thinning effect. And when you study the thyroid and the parathyroid hormone, they regulate calcium metabolism, so you can see how those illnesses would cause osteoporosis. And then when you think that you need calcium and vitamin D to be absorbed from the small intestine, if you have malabsorption disorders like celiac disease or surgery or anything that's going to limit that absorption through the intestine, you're going to possibly get osteoporosis. And so it's often seen as a woman's disease, osteoporosis, and it is more prevalent in women. As I mentioned, 1 in 2 women will get it in their lifetime. And there are several reasons for that. Women have a lower peak bone mass, and that is peak bone mass is around 30 to 35 years of age. And as far as bone is concerned, it's all downhill after that. It's very difficult to build up bone after that. Estrogen is critically important for maintaining bone strength. There are signalling receptors on the osteoclast which build up bone. So, as I mentioned, at the time of menopause, when it falls precipitously, then there's bone loss and there's continued bone loss after that time. And men do lose testosterone, which is an anabolic bone builder, but they lose it at a much slower rate, so they don't have a precipitous fall like women do at menopause. So it doesn't mean they can't get osteoporosis, but there isn't that window of bone falling. Although there are conditions like hypogonadism where there might be low testosterone for other reasons, and then younger men will be getting osteoporosis. But the problem is the impact of fracture on men is greater than that for women. There is more morbidity and more mortality, that much less of them, even less than 25% of those with osteoporosis get investigation and treatment. So to come to the treatments, I'll just go through them briefly, but the most common ones, and the one that was talked about with Alma, is Fosamax, and it's a bisphosphonate. And it's called an anti-resorbative. So what it does, it stops the osteoclast from breaking down the bone. So when we talked about the bone biology, how that balance of breaking down and building up, it restores that balance to some degree. But it stops the decline in osteoporosis, but it's not anabolic, it doesn't build up bone. Selective estrogen receptor modulators, again, the estrogen, they're supplying estrogen, but they don't have breast cancer risk associated with them. Hormone replacement therapy was used for a long time for bones, and also because it treated symptoms and other issues around menopause. But you're probably aware there was a huge study that linked it with increased breast cancer. That has now, being questioned, and even the way the large study was, but generally it's no longer a first-line treatment. But because people are now using hormone therapy more for symptoms and are less scared of its breast cancer side effects, it can have the added effect of preventing osteoporosis. There's something called strontium acetate, and you take that in a liquid form. It's a different form from the bisphosphonates. And because it's used daily, it's not so common. And denosumab is quite new. It's a monoclonal antibody. It's a new type of drug. It's only been in use probably for a year and a half in Australia. It's only 2 injections, and it's very good because you don't have those problems of compliance. And possibly someone like Alma, who was on about 12 medications, this would have been a suitable thing for her. And teriparatide is only used in severe cases. It's when people continue to fracture, even on treatment, and it's an analogue of parathyroid hormone. And it works like a parathyroid hormone, and it's about the only anabolic building up bone treatment that we have. I think I'm coming to a close, but I hope I've left you with the view that osteoporosis causes severe morbidity and mortality. There's good treatments. It's unreasonable to leave osteoporosis untreated, as it leads to high blood pressure or high cholesterol untreated. And especially if someone has a low trauma fracture, that's a really important time to be aggressive with treatment because you're trying to prevent that next fracture in the year following. But when we talk about all these treatments and prevention of osteoporosis, it's all a little bit too late. It's all going to stop declining bone and maybe stop a second fracture. But if we want to look at a population base or on a larger scale, the way to prevent osteoporosis is to have the greatest peak bone mass. And that's sort of why bone density compares to a 35-year-old, because after 30, everyone's bone starts to decline in density. And what's the best way to get that peak bone mass is to have exercise that has a mechanical load that builds up bone. And that's better than swimming and things, well, there's probably not other things that don't use gravity. And it's also really important to have a good calcium intake before 25, and also vitamin D as well. And in countries like Canada, they recognise this, where there's hardly any sun. It is extremely difficult for people to get that exposure. Foods are fortified with vitamin D, and especially for children, so that they don't miss out on a peak bone mass. So none of you can imagine being old, but for this osteoporosis lecture, for yourself, to achieve peak bone mass before it all starts declining, check that you have adequate calcium intake, weight-bearing exercise, get out and get some exposure to sunlight. And I hope I've sparked some interest in osteoporosis. I'm really happy to answer any questions by email. I've had very interesting questions after these lectures in the past. Thank you. That's okay? No, that's...
We should probably go at election time now. I can maybe go based on that. Because election time was. So you can
Hi everyone. Oh, just make it louder. Yeah. Hi everyone. Okay. A few quick announcements. One thing is ASOC opening night is tonight, so that's the anaesthetics intensive care